Thank you all for having me. Thank you so much to BCNA. It is so nice. It's weird. I mean, there's absolutely no doubt that online stuff is easy to use and it means that our messages get out to more people, but there is nothing like looking at each other in the eyes in the flesh. The weird thing is, though, I've forgotten how to time a talk, so I think Kathy's going to wave at me and yell out because, and as I said in the last talk, if I slip off my shoes, don't be offended. So you've been very generous. You've given me 40 minutes, which is a long time to hear me talk, and I think we might get bored before that. And the best part is the questions. If I say something that doesn't make sense, yell out in the middle of the talk, because we don't want to move on without addressing that. But save your questions until the end. But hopefully I can get through the slides in earlier than 40 minutes, because we may need another cup of tea by then. So these are the topics that I've been asked to speak on, and I'll try and stick to this, but you may have other issues that you'd like to ask me, and you can ask me absolutely anything. And as I say to everyone, if I don't know the answer, I'll ask someone else. So we're kind of going to gently walk through early breast cancer. I can't cover everything today, and nor would you want me to, but I think what we're going to do, certainly a lot of these issues I suspect have come from you, because oftentimes these are the contentious things that come up around a diagnosis. Now, I am a medical oncologist, so you are getting the kind of, oncologist, physician's perspective here. So I'm not a surgeon, I'm not a radiation oncologist, so it does have that bent. I should just declare that. So we'll see how we go. We're right on 10. So the first thing to say is that, how many types of breast cancer are there? And there's probably, at least a dozen. But realistically, when we're talking about breast cancer, we're really thinking about the three main types of breast cancer. And we've divided them up into three types because those types really help to decide how best to treat them. And so most breast cancer is driven by estrogen, the dominant hormone in females and in males, but the dominant hormone in females. And the reason breast cancer can come up without you knowing it's there is because it can sit there quite nicely in the breast and sometimes in other places, and you really don't know about it because the body tolerates that quite well. Our immune system doesn't really recognise that it's there, which can be very frustrating. And that's because estrogen is endogenous. It's in us all, we like it, which is why when I take it away using some of our drugs, it's often not pleasant. So estrogen drives most early breast cancer, okay? But there are other types of breast cancer. So if we think about estrogen, that's probably about 80% of the breast cancer that we see, maybe getting closer to 90% actually if we look at the next 10-year predictions. But the other types of breast cancer are certainly not rare, and they're something that certainly when patients are talking to each other, they say, well, hold on, that lady didn't have a HER2-positive breast cancer, that's what I've got, what does that mean? So HER2 is a protein that's ramped up or driven, it's all over our bodies actually, but in about 1 in 6 women, this protein is going to be the reason they got breast cancer. These type of breast cancers can also have estrogen on them. They may not. It's about a 50-50 split there. But these are breast cancers where in the old days, and KP just referred to the drug Herceptin, if I was seeing a lady with a HER2-positive breast cancer, I'd say, look, this is a more aggressive breast cancer, and the outcomes, unfortunately, are not as good. The good news is now is because of the drugs we have in this setting, the outcomes for this type of breast cancer are just as good and perhaps even better than some of the other types of breast cancer because the drugs make such a difference. So a nice story for HER2-positive disease, and we might talk a little bit about that today. Triple-negative breast cancer, it makes up about 10% of early breast cancer, or probably between 7 and 10%. And it's frustrating because this is defined by what it isn't. So estrogen doesn't play a role here, the other hormone progesterone doesn't play a role here, and that HER2 protein is also not relevant. So triple-negative breast cancer is often the one where chemotherapy is required. And actually it's often the one where a lot of our new drugs are being tested to ideally get rid of chemotherapy, which I'm sad to say we haven't done yet. But certainly this is the type of breast cancer where potentially adding immunotherapy is what is going to make a real difference. And I'm going to talk about that at the end of my slides. So I think I've already kind of really got to this, but basically the pie chart's a little bit out of date, but basically about 80% estrogen driven, maybe about 15% is this HER2 protein, and then a small amount, around 10% being triple negative. And so when we think about how we treat these subtypes of breast cancer, we're really thinking about what's the main driver to be able to block that so that the cancer never comes back. And when I'm treating ladies and men in this setting, our aim is that the cancer never comes back. Whether you call that a cure or not, I don't know, but we don't want that cancer to come back somewhere else. We don't want that cancer to come back in the place where it started. And we actually don't want there to be a second episode of breast cancer, which is something else that our drugs help to prevent. So estrogen therapy is by far, or anti-estrogen therapy really, because it's getting rid of estrogen or blocking estrogen, is the mainstay of treatment for these breast cancers. And virtually all patients who are diagnosed with this type of breast cancer will be offered that treatment for one reason or another. For HER2-positive breast cancer, we've got drugs directly against that HER2 protein, and I'm pleased that they work very well. The snag is, in early breast cancer, they're almost always combined with chemotherapy. And so for HER2-positive breast cancer, the story is often a lot of treatment, even when it's a small cancer, but it makes a huge difference. The outcome from these cancers is really actually fantastic for the vast majority of patients, but the drugs are really important. And then for triple-negative breast cancer, we're really predominantly giving drugs before the surgery, and we're going to talk about that a little bit later. And these drugs are often chemotherapy. And the beauty of giving it before surgery is we get to know how well that drug is working, or those drugs are working, and we get to change them depending on the response. So just so we're all on the one page, when I say early breast cancer, because, I don't think we all think the same here, but early breast cancer, and this is my opinion, so you're welcome to dissent, but is really saying this is breast cancer that's basically in the region of the breast. If it's gone to an organ away from there, that's stage 4 disease, advanced disease, metastatic disease that we won't talk about today. Anything else is early breast cancer. Now, you might say, well, is stage 3 breast cancer early breast cancer? I'm calling it early breast cancer because we still aim to achieve a cure. We do not always achieve a cure, but we aim to achieve a cure. So we do not shortchange ladies with stage 3 disease, because our hope is that by giving our best therapies, we have the best chance that the cancer will not come back. So there's a couple of features when we're thinking about early breast cancer. Generally, the treatment has got a beginning and an end, although that end might be many years down the track. And generally, the treatment, for example, the chemotherapy, is given for a very fixed, protocolised range of time, for example, 3 to 6 months. Now, not everybody with early breast cancer, as many of you will know, need chemotherapy. And with some slides coming, I hope you're delighted to know that we're giving less and less chemotherapy. And I'd love to be standing here one day saying we don't need it at all, but I think that's going to be a long way down the track, because it really does help for some women and men. So when we talk, and I'm going to predominantly just now focus on the majority of breast cancer, which is that estrogen-positive breast cancer, and then I think we can talk about the other subtypes if we have time. But what I spend a lot of time with patients trying to decide, so the standard way a patient would come to me is they will have been diagnosed either by screening, or they'll have felt something or seen something. They will go for surgery first, and then they'll come and see me to have a chat about, is anything else needed? And so my role as a medical oncologist is to say, what's the chance that there are some cells lurking about somewhere that I can't see, you can't see, no scans can see, that are still there? Because if there's absolutely no chance, and it's pretty much never an absolute zero, but it sometimes gets very close to that, then actually anything I give won't make a difference, because you're cured, okay? It means that the surgeon and potentially the radiotherapy did its bit. But the problem with breast cancer is it can be frustratingly unpredictable. And so my role is to say, well, what's the chance of there being those cells lurking about somewhere? And if that chance is a reasonable, intermediate to high risk chance, then what is the best therapy that I can give to reduce that chance so that this cancer never comes back? Okay? And the reason I like to spend a little bit of time on that is oftentimes when ladies and men are sitting in my room, they think, whatever I'm about to talk about is an absolute barn door guarantee that 1, they need it, and 2, that it's going to work. And it's not always like that. And some of the longest consultations we have are because my treatment makes a really small difference. And so we've got to decide, is the toxicity of that treatment worth it? And that's a decision that you can only make with the best information you have at hand. And sometimes that best information changes as we go on. So when we're thinking about an early breast cancer, so say a patient who's had surgery and they're coming to see me, let's say they had a node that was taken out at surgery and had the cancer in it. Our aim is that the cancer never comes back. And so our decision there is, well, it is driven by estrogen. It is estrogen positive. It might be very strongly estrogen positive. And so giving agents to block estrogen or reduce estrogen are what we do. And they are generally tablets, but you've got to take them for a long time. So you don't take them for 3 weeks. You've got to take them for years, sometimes 5 years, sometimes longer. Not everybody needs longer, but sometimes longer. And the job of that is because if there are any of these cells that need estrogen and they cannot see that estrogen, actually we aim to kill them, okay? So oftentimes people say chemotherapy does the killing job and endocrine therapy actually is just there to keep everything at bay. Actually, it's kind of, endocrine therapy works extremely well to kill cells. Often the elephant in the room, though, is, but do I need chemotherapy? The surgeon said maybe, and that's often, before even people get into my room, I can see that that's the biggest concern for them. And that is our job, to try and help to know what additional role chemotherapy will have in addition to that hormone therapy to increase that chance of cure. And I'm going to spend a little bit of time on that today. We've got some other drugs, though, that make a difference. So I think probably the one that's pretty exciting is that a drug that treats osteoporosis when you don't have osteoporosis at similar doses to men and women out there who have osteoporosis actually helps to reduce cancer coming back, breast cancer. I mean, that's phenomenal. Why would a drug that, helps strengthen your bones in men and women who don't have osteoporosis reduce the risk of the cancer coming back? Now, it's a small benefit, but listen, it's a pretty simple drug to give, so why wouldn't you add it to the regime? Okay, so I won't spend too much time on that. Unfortunately, they are not PBS indicated for breast cancer, but most hospitals will give them to you and pay for them because they're not expensive and we feel as though it's worth it. So if you're interested in that and you haven't spoken to your team about that, I would certainly bring it up. And obviously, one thing that we won't talk about, although I'm sure you're having some talks today, is about what can be done that's not on a script, okay? Probably should be on a script, actually. The importance of keeping the weight down, which can be very difficult during chemotherapy. It can be even more challenging when I reduce estrogen because it kind of slows the metabolism. But trying to control weight is really important and, I admit can be really, really challenging. Exercise is your best friend. And, having walked in COVID, and certainly after today, KP, I won't be walking very far with these heels, but, the truth is keeping active is important because whatever drugs I'm thinking of using, the more active you are, the faster they go in and the faster they get out. And that's good for me, and that's certainly good for you, and it's very good for the cancer. Well, it's bad for the cancer. But the problem with these is they're often much harder to give than a script. A script, can be easy to give, can be hard to take. But doing these other things in our lifestyle, especially at a time that is probably, a catastrophic event in someone's life, it's pretty hard to say, listen, you've got to stop smoking, all right? So I think these are often conversations that we have to have, and we often need a team to help. So what do we know from the pathologist? So when you come and see me, you've had your surgery, and you say, well, Belinda, how are you going to decide what I need? And the truth is, we base this on very good information. So what the tumour looked like under the microscope, so was it a cancer that was growing very quickly or not? Were the lymph nodes involved when they were sampled or potentially taken out? How strong was the estrogen signal? Did these tumour cells look like they were completely addicted to estrogen, or really did they kind of look like it? It's a bit like, lights on a Christmas tree. You can have all the lights on and they're on the brightest. If that's very strongly estrogen driven, then anti-estrogen therapy is the mainstay of treatment. If the lights are only half working and they're not that bright, then probably we're going to need some chemotherapy as well, because it looks like some of those cells may be able to survive without it. And then, of course, you cannot actually forget about the patient sitting in front of you. So I might have a plan in my head before I've met you, but that plan cannot actually be really formulated until we actually meet, we have a chat. And oftentimes I say to my registrars, they'll come in and they say, right, I'm about to see, Mrs. So-and-so, I'm not sure, what we should do. And I go, meet her first and then come back. And oftentimes it's very clear after we've met. Menopausal status does make a difference in terms of what therapies we can choose. And unfortunately, and I say that as unfortunately, for young women who are diagnosed with breast cancer, getting rid of the estrogen, which is hard in older women, but I tell you it's really hard in younger women, actually does make a difference to the cancer returning. So getting rid of a lot of the estrogen is really important. But these treatments have actually got to be doable because they go for a while. Other medical issues we do have to take into consideration, and of course, what does the patient want? And when I say that, I mean my job is to make sure that they can make an informed decision, and one appointment may not be enough. So it looks like a traffic light system. It makes it really simple here, but it's not very simple at all. And generally what we think is low-risk breast cancers generally don't need chemotherapy, but they probably need hormone therapy if they're estrogen positive. High-risk breast cancers generally will be, patients with high-risk breast cancers will be offered both treatments, and somewhere in the middle is a little bit murky. But the good news is actually that we're learning that this intermediate risk breast cancer, which actually, if you look at the grey and the green group, are the majority of ladies diagnosed with breast cancer, actually we're learning more and more that less and less chemotherapy is needed. So I'm going to talk a little bit about chemotherapy because I give a lot of it, and it is tough. You know, most patients get through it. Most patients are not admitted for chemotherapy. They're admitted for the chemo, but they don't run into trouble where they need to come into hospital, which is very different to a decade ago. But the problem is every time we find a new drug that helps a little bit more and we add it to the pile of chemotherapy, we've got to be aware that it probably does add some side effects. And this slide's old now, actually, it's over 10 years old. I probably need actually the fourth graph, because now what we're doing is we're actually trying to get rid of some of the more toxic drugs because we've become a bit more clever about how we give chemotherapy. Also, we're getting better at dealing with the side effects. So I mentioned not many patients are admitted when their blood count's low and they get fevers. Even in the era of COVID, I'm pleased to say that's the case, because we give what's called growth factor support to try and stimulate the bone marrow. When the chemotherapy is given, the white cell count goes low. That's when the risk of infection is the worst. But these injections to stimulate the marrow reduce the time when the counts are low. And really important, because any admission to hospital that can be avoided, I think, is worth it. Most of our chemotherapy in early breast cancer, unfortunately, you still lose your hair. Now, we do have scalp cooling, which some of you may have used, some of you may have hated. I've got patients where that is the worst part of the treatment, and it doesn't always work. And I think the machines are getting a little bit better, but there's no doubt about it. You know, a freezing cold experience for your first half an hour of having treatment when you're trying to get through all these other issues can actually be the worst part. The other thing I'd say is wigs, you know, hair coverings and things like that are really quite phenomenal these days. So I see patients and I actually honestly don't know if they've got hair or not. And that's because there are many options now available. And of course, fertility preservation techniques are getting better and better and better. And I'm sure if you haven't been to some of the talks we've had from experts in this field, you will know that they're very good at being able to stimulate cycles. We don't have to wait for women to get a period, so we're not delaying their treatment. And the success rate of these storing facilities are really good. They also need to be affordable. We can talk about that. So if you said to me, well, say you've got a patient who's got a really borderline cancer, and I think as a clinician it's a difficult decision to decide chemotherapy. I've got the information that's in the pot from the pathologist. Is there any other information that could be worthwhile? And a lot of patients are frustrated because there are these tests out there you can buy but are not funded by Medicare. They're not funded by your private health insurance. These are out-of-pocket costs, and they are not small. They are thousands of dollars, where we take a slice of the cancer that's been taken out, and we send it off, and they mush it up. And instead of looking at staining, remember the Christmas tree lights, they mush it up and they look at the genes in the tumour, not in the patient, in the tumour. And they look to see, they put it through a magic black box, and it comes up with a risk of the cancer coming back. Now, it does something very similar to what I do in the room with the patient with the information that I have. So these tests, because they cost a lot of money, because most people can't get them, and because they deal with genes, people think they're magic, right? The reality is they're not magic. Like, I've developed one myself. It wouldn't surprise you, it's not commercially available. But the reality is that they do provide sometimes some extra information to help make that decision. But the good news is they're not the panacea. And as a clinician, where I honestly 10 years ago ordered a lot more of these tests, they weren't funded then either, it would be great to have access to these for the patients who need it, but not everybody needs these tests. And if they were funded tomorrow, I would still not use it in all breast cancers. But I mention them because a lot of patients do ask us about them, particularly if you've talked to colleagues overseas where they are funded and you think, how come I can't get this test for my cancer? So what I would ask you in this current climate, unless we are successful in getting these funded, is that if you feel you need this, I think you should talk to your oncologist and ask them, well, the most important thing you ask is, what would you do without this test? And then what would you do depending on the result? And you ask those questions before you pay for the test. You don't pay for the test and then realise afterwards that it wouldn't have changed the decision. So really important to put your medical oncologist through that exercise. If you do use these tests, you give less chemotherapy, okay? Now, that might make you think, oh my God, we have to be using this because we don't want to give chemotherapy unnecessarily, and we don't. But we've also learnt from these tests So actually, even in Australia, we're giving much less chemotherapy than we used to. And the biggest reason for that is we've worked out how better to listen to our pathologist. But certainly, and when I'm talking to clinicians, I say this, if you give a lot of chemotherapy, if your knee-jerk reaction is to just give chemo because you can, which is why I put that slide up before, then you should actually use more of these tests or tests like this, because they will actually change your decision-making. So I'm just going to talk about 2 studies because I'm going to mention them, not because I want you to all go and ask for this test, but I'm going to show you how we've come a long way in breast cancer. So you don't really have to understand anything that's on the slide, but this was a study asking for women in that kind of intermediate risk range where maybe it's a bit difficult to know what the role of chemotherapy was. This was a study that randomised thousands of women to either having hormone treatment alone or chemo and hormone treatment. Pretty difficult study to go into as a patient because you get randomised and, I don't know whether the patients who got the chemo would have thought, damn it, I got the chemo, and the patients who didn't would have thought, well, hold on, how do they know? Anyway, so you've got to admire the thousands of patients who went into this study. The good news is, you probably can't even see that, but there are 2 lines sitting right on top of each other. There's a dotted line and a red line, and they're sitting right on top of each other. What that means is that it actually made no difference at all. So in this particular study, it showed that chemotherapy added no benefit at all. And as an oncologist, the way we use this information is not to go and order the tests, because as I said to you, they're unaffordable and we can't do them. But what that says to you is if my patient fit the criteria for this, adding chemotherapy wouldn't make any difference. And that's great news because some of these patients before this data would have been offered and certainly had chemotherapy. That study was in patients where the lymph nodes weren't involved, okay? And to be fair to the study, a lot of those patients would not have got chemotherapy even without that study, but some of them certainly would. Probably a much more difficult decision is what if there are lymph nodes involved? Now, if there's a lot of lymph nodes involved, we tend to give chemotherapy. But what if there's only one, which is the most common thing to find? And this is another study. They did the same test to really ask that question. Again, separating out, randomising patients. They didn't get to choose between giving them chemo and the hormone treatment or hormone treatment alone. And you might say to me, oh, well, Belinda, I can see the 2 lines, which you can. But basically, I should mention, in the overall population, there wasn't really a difference. But the main message out of this study was if you're postmenopausal and you had a node positive, having the chemo didn't make a difference. Now, most of these women only had 1 positive node, but that's a massive change to many clinicians' practice. And look, my whole research has been in trying to give less chemotherapy, but not everybody thinks the same way. And certainly traditionally we tend to overtreat people rather than really it's easier to give it and say, well, we did it. And some patients would still say, I don't care if it's a 2% benefit, Belinda, I still want it. And that might be okay and we might still proceed. But my job is to say, well, if there's a 2% chance of serious side effects, am I really doing you the best service? So this is a fantastic study for postmenopausal women, helping us to do less toxic treatments because they don't actually make any difference. What can we do about estrogen? Okay, because our bodies basically love it. I mean, when we block estrogen, some people get away without any side effects, but most of us love estrogen. And I was saying in the last talk, it's not about how much estrogen you've got. I get asked that all the time. I had my estrogen levels done, they're up here, is that why I got breast cancer? No, because actually most people who get breast cancer are postmenopausal, and postmenopausal women have a lot less estrogen than premenopausal women. So it's not so much the volume of estrogen we've got, it's what we do with it. And so there's 2 ways we can get rid of or block estrogen. The easiest way, or the most easiest way for patients, is to use tamoxifen. Tamoxifen is a super clever drug. It was developed as a fertility drug, so you can get pregnant on it. We don't want ladies to get pregnant on it. But what tamoxifen does is no matter how much estrogen you've got, whether you're premenopausal, you've got this much, whether you're postmenopausal, you haven't got much, but you've got a little bit, no matter how much estrogen is there, tamoxifen blocks it, okay? Doesn't get rid of it, but it blocks it. Very clever drug. It's our oldest drug in breast cancer and still works very effectively for the majority of women. In postmenopausal women, however, as you can imagine, so say you've got about this much estrogen and use tamoxifen, it creates a blocker. But there are drugs called aromatase inhibitors, which many of you will be on, which actually deplete you of estrogen. They stop you being able to produce estrogen. And it probably is no surprise that for high-risk breast cancer and some intermediate-risk breast cancer, that's a better way to go. Now, I'll skip through these slides, but it's probably no surprises to people in the room that if you get rid of every skerrick of estrogen, there is a price to pay. And the classic thing we see here is hot flushes. We see that with tamoxifen as well. Interrupted sleep, it affects your libido. You get a dry vagina. You can sometimes get urinary tract infections, not actually because there's an infection there, but because the dryness of the area creates problems with bladder emptying. And of course, because your bones love estrogen, these drugs deplete you of estrogen. And so you can get osteopenia, which is slightly thin bones that many of us have, or osteoporosis, where you often need treatment directed against that. Because being cured from breast cancer is important, but fracturing your hip from osteoporosis is a terrible thing to happen. We certainly don't want that either. So we've got choices with regards to our endocrine therapy, and tamoxifen's kind of been given the boot a bit, but the reality is tamoxifen is still a very effective drug. And even in ladies where aromatase inhibitors might be the choice, if you can't tolerate it, then tamoxifen is still a very good option. Tamoxifen's not a walk in the park though. Hot flushes are still a big issue with tamoxifen. The one thing I want to say about the bones with aromatase inhibitors is if you're going to lose bone from my drug, you're going to lose it early, in the first year or 18 months. And so being really aggressive, keeping an eye on the bones, exercising, going up hills, I say weights, but I don't go to the gym, but going up hills actually, doing some squats is probably the best thing you can do for resistance to help improve or maintain bone density. The trouble is none of us really go out in the sun anymore. We're often vitamin D depleted, particularly in winter, and that's not good for your bones either. So the first 12 to 18 months on these drugs is the most important. If you're 7 years in and you're still on an aromatase inhibitor and your bone density is, like this and it hasn't changed, it's not going to change from the drug. It all happens in the first couple of years. And that's why, getting back to that first slide I showed, where being really aggressive with the bones and potentially even having a drug when you don't even have osteoporosis can actually help to prevent losing bone density, and it happens to reduce the breast cancer coming back. So, to me, it's a no-brainer. Stopping smoking and minimising alcohol is also important, obviously, for breast cancer, but it's actually really important for bone health as well. And avoiding medications, sometimes you can't do this, but things like steroids. And I think as a medical oncologist, we underestimate. Steroids are the drugs we often give with chemotherapy to help with nausea, sometimes to help stop a reaction, but they're not great for your bones either. And so oftentimes some of the problems with the bones may not have always been from the pills, they may have been from the chemotherapy that we've given. So I'm not an endocrinologist, but I have an endocrinologist who works with me on a Thursday, and I basically got him sewn to me because it's really important to look after your bones for breast cancer. The problem with our hormone treatments is, how intensive do you need to be? We've touched a little on that. And how long do you need to take these darn things, okay? And I think we are far too often, if you Google it, it says 10 years, Most women actually do not need 10 years of these drugs. That's the data. Most women, even with high-risk disease, do not need 10 years. And so that is a nuanced decision that you make depending on what the cancer is, where you are, and probably the most important thing is how well you tolerate them. And a frustrating part about breast cancer, especially breast cancer that's driven by estrogen, is there's actually nothing terribly special about the risk at 1 year, 2 year, 3 year, 6 year. And it's a really frustrating thing about ER-positive breast cancer. Triple-negative breast cancer, if it's going to come back, it'll come back in the first few years. So if you get through those first few years, your odds are you're probably cured. There's always exceptions, but you've got to take the data that you're probably cured. Whereas estrogen-positive breast cancer just has this habit where it can come back later. Now, it doesn't mean we can't treat it, but it is a different scenario if we're in the advanced setting. So one of the things, and again I tell the registrars this, but you learn this the more you see patients, is whilst in the beginning I might have a very clear plan of how we use our treatments, and our aim is to try and keep the treatments ongoing and manage the side effects as best we can, especially if there is a big benefit from the drug. But 5 years is a very different scenario, and I'm sure some of you might have heard me say this before. At 5 years, the patient tells me, they walk in and they either hand the pills back and they say, "Belinda, it's been lovely, but I'm gone and don't give me another script." Or they say, "You can't be serious, you're not going to stop it. That is my security blanket, that is my linchpin, I've learned how to tolerate it well, don't you dare take it off me." And so that is the balance at 5 years. So if you're in the early stage and you're thinking, "Oh my goodness, what am I going to do at the 5-year mark?" Don't decide that now. We never decide that now. We take one step at a time. So 5 years is often a discussion which the patient really decides for me. But you might find, if you want to write this down, or certainly anyone can have the slides, this is quite a fun calculator for 5 years. If you are at 5 years or beyond and you're trying to work out, well, what's that risk? Belinda said, you know, it could come back later. What is actually the risk of that? This is something that my old boss and his colleagues actually developed. It's online, it's free. You shouldn't probably do it on your own, but you should do it with your medical oncologist. And I only say that just because you want to put in the data correctly, which tries to estimate what the chance of the cancer coming back after 5 years is, so that it can help inform you whether you want to continue treatment or not. I'm moving through. Male breast cancer often gets left out of talks. It even gets left out of data. So we just had our Victorian Breast Cancer Summit last year, and we presented the data and we were forced to take out the male breast cancers. I mean, that's crazy. So I thought I'd just put this up here just to show you, you know, what kind of numbers. So this is just Victorian data. It's not perfect. It's, you know, there's a few holes in this, but just to give you a bit of a sense. So between 14 and 18 in Victoria, there are 136 male patients diagnosed with breast cancer. Now, the good news is that even though obviously there's no screening for men, most of them were early stage. So men generally would not be able to present unless they get a symptom on the whole. But the good news is most of them are still early stage. And so when I'm seeing men with breast cancer, the options to them on the whole are discussed in a very similar way to women. The hormone treatment options are a little bit different, and tamoxifen is used more often in men than the aromatase inhibitors, although that's not exclusively always the case. But I just thought I'd put that slide up there just to remind us that, you know, whilst I know this is the, you know, minority of breast cancer, we certainly can't forget men. I have been asked just to mention neoadjuvant therapy. I've got 10 minutes left. Okay, I don't know. I have no idea where we are in the deck, but we'll keep. Okay. Neoadjuvant therapy. So some of you might have had neoadjuvant therapy. What is it? So generally the surgeon goes first, so they're the most important person in the room. I always say this, I'd travel to the other side of the world for, well, not necessarily, I probably wouldn't actually, but I'd travel for a really good surgeon, I would. Would I travel to the other side of the town for me? I wouldn't actually, because you want to get on with your oncologist. You want to make sure you have a good relationship with all of your team. But a lot of what we do is very protocolized. There's very, you know, kind of clear guidelines. And I often say to patients, you know, if you saw 100 of me around town, you're welcome to do it, but don't, is I'll give you a sense of, you know, we are likely to all agree. And sometimes I do have to say to patients, listen, if you saw 100 of us, there'd be a 50-50 split. And the patients often look up and say, Belinda, you can't be kidding. Like, how come you can't all agree? And usually that's the case where the treatment for that breast cancer is probably going to make a very small difference. And that's why we flip. If it's a very clear indication to have everything, you know, then we're probably all going to recommend it. But anyway, I've diverted. So the surgeon is often the number one. So if the surgeon doesn't operate first and we go first and give drug treatment, that's called neoadjuvant therapy. Adjuvant means after surgery, neoadjuvant means before. And you can have anything. It's usually chemotherapy, but you can have hormone therapy, you can even have radiotherapy sometimes, and you can have some of those HER2 therapies. So neoadjuvant therapy is trying to give a drug before the cancer is taken out rather than the other way around. And there's actually a lot of reasons why we do this, and we're getting more and more. You know, most patients, you know, you feel something, you're told it's breast cancer, the initial reaction is, thank you, take it off. You've got to be kidding, I'm not going to sit around with Belinda for 6 months, take it off. Very reasonable reaction. But there's actually a lot of good data now as to why for some cancers, doing drug therapy first is a good idea. It's not for everyone. Actually, it's not for the majority of breast cancer, but some of the breast cancers, particularly that HER2 positive and the triple negative, you know, if I was diagnosed with that breast cancer, and I often say I treat you if it was me, my sister or my mum, then it is a better way to go. And there's a couple of reasons why. When we give the drugs while the breast cancer is in the breast and maybe in the nodes, we get to know if it works, because you can feel it. Often the patient knows before I see them. Usually you can feel it, and we can examine you, and if we need to, we can do scans. And the reason that's really important is after surgery, patients say to me, well, you're going to give me 6 months of chemo, Belinda, how do you know if it works? We just give it, and we cross our fingers and say, well, we've done it now. It's like that insurance policy. It's a funny thing to say, but, you know, insurance policy chemotherapy sounds a bit weird. But in the neoadjuvant setting, we know if it's working because we can watch it. And if it's not working, we can tailor it. We can add drugs in, we can take drugs away. And what we're now seeing is there's data that if you have this kind of approach for the more high-risk breast cancers, and you can tailor the treatment even after the surgery, you actually live longer. It's got to be the best reason to have this approach. So we are finding that more and more patients are going and kind of, doing the reverse order. They meet the surgeon, then they come and stay with us for what can be several months. Hormone treatment can be used in this setting, but it's not several months. It's usually up to 9 or even 12 months. So it's not as common to use the hormone treatments in the neoadjuvant setting, but sometimes we do use them, and they often work extremely well, but it's quite a long time to sit around and see whether you're a responder. The other thing is, if you have treatment first, it gives time to make some of those really difficult decisions. Am I going to get a mastectomy? Do I need a reconstruction? What type of reconstruction? What am I going to do about my other breast? What am I going to do about work? What am I going to do about my finances? What if I have a gene fault? What if I have a BRCA mutation? All of that cannot be decided in 3 weeks, which is usually when we want to decide treatment. So if you've got 6 months to make that decision, because you'll be on drugs that should be treating the breast cancer, then that's absolutely got to be a better way to do it. So as I said, not for everybody, but certainly for a significant proportion of patients. The other thing is that this is a space where often we are testing new drugs, because if we test new drugs when the cancer's there, we can know whether or not they work. Whereas the traditional model of clinical trials in early breast cancer is to give drugs to thousands and thousands of women and then wait 10 years, then publish the paper, and then maybe the drug will suddenly be recommended, and then 5 years later you'll get it on the PBS. Too slow, way too slow. So this is another reason why when we're testing new drugs, if you know it works because you can biopsy the tumour if you need to and see whether it's killing the cancer cells, it's probably going to lead to having access to these drugs even sooner. Does subtype matter? It does, but I'm going to just jump over that for the minute because I think Kathy's going to wave me down. So interestingly, when I usually give these talks and I'm talking about advanced breast cancer, I usually talk about immunotherapy. And something really interesting has happened over the last 12 months, 2 years, is that immunotherapy in metastatic breast cancer is still not fantastic. Works for some, not very many. We still haven't got it in Australia for maybe several reasons that are not always, what we would like. But the reality is they're not revolutionising metastatic breast cancer. I actually think that immunotherapy will probably, and this is just my opinion, will probably be available in the early breast cancer setting. And when I say available, what I mean is funded, because that's the only way we're going to be able to use them properly for all our patients. But I have a feeling this is the space where immunotherapy may actually be available for patients in Australia. And that's because in the metastatic setting, there's a very small proportion of women where the immune system is switched on and you do something with the immune system. Yes, you give chemotherapy as well, and it works and it improves the outcome. What's interesting in early breast cancer, and it's probably because the breast cancer hasn't been there long enough and the immune system isn't totally clapped out by the treatments, is that it's looking like immunotherapy, unfortunately still with chemotherapy, is actually showing responses in early breast cancer, and it does make patients live longer. Now, it's not yet in the most common type of breast cancer, which is that estrogen positive one. Because remember what I said, estrogen, immune system couldn't really care. But in triple negative breast cancer in the early setting, adding immunotherapy is starting to make a difference. And there's 2 studies here, and I'll just show you why it's really important that we do these neoadjuvant studies, is that study of a drug called pembrolizumab meant you had to give it before the surgery, after the surgery, and for a year or 2. And that, for a funder, is going to cost hundreds of thousands of dollars until these drugs get cheaper. This is a study where they just got it before surgery, so they maybe got between 4 and 6 doses, and it made them live longer. And so this is, I actually think, where potentially it is actually really going to change the ability for patients to get access to immunotherapy. The snag with immunotherapy is if I give you an agent that upsets your immune system, it can also upset your immune system, which is really important. Your eyes, your skin, your liver, your lungs. Every single part of you can be inflamed when you give immunotherapy. So as a medical oncologist, I'm quite used to dealing with the side effects of chemotherapy and hormone therapy, but this is a new field for us. And I think what we have to be really careful of is that when we find a drug that increases the chance of cure, that's really important. But if there's any potential, even small, long-term side effects from these drugs, you have to educate patients as to whether they want to take that risk. Now, the most common one is, knocking off your thyroid and needing to be on thyroid medications for the rest of your life. Now, that's not great, okay? But it might be manageable if this is the right thing to add to your therapy. What's not good if it causes neurological symptoms that shortens your life, might have cured the breast cancer but shortens your life. And this is the delicate balance of adding new drugs into early breast cancer. I think I'm getting near to the end, so I'm going to skip over that. Do you want me to, how am I going? I said I wouldn't talk for 40 minutes and I have. It's under 40. Okay, I'll just end with this, a little bit of pie in the sky experimental stuff, because the most common question I get asked, and I expect maybe someone will ask me today, is how come I'm not getting scans? How come my oncologist said to me, okay, you've had all the treatment, now you're a year down the track and you say, I want a scan of my whole body, I want to know it's not back, and the oncologist says, no data to do that. I think it is the most frustrating comment that people like me make. And so I just might go over that in preempting that question, and then I'll talk about this. And the reason we say that is because from studies from patients treated literally decades ago, so it's old-fashioned, is that it didn't show that it made a difference to people's outcome long-term. So scanning women from head to toe with scans like CT scans actually didn't make them live longer when they're well. Now, as a patient, and I get this all the time, they say, well, I don't care about the study, I just want you to scan me because I want to know. And I get that, I totally get that, especially for women who may have been diagnosed with a lot of lymph nodes, they've been through all this treatment, and they say to me, I just want to have a scan. So my job is to say to them, well, look, the data suggests that, if I scan you today and we find something when you're well, or we didn't scan you and in 3 months you came to see me and you said, you know what, I've got a sore shoulder, can we scan you? And I found the breast cancer. Even though the data says you actually will live the same amount of time, as long as you educate patients about that decision, I don't think as a shared decision between your team it is unreasonable. The problem is if you have a scan when you're well, it's not always reassuring. And in fact, I've got a lady just at the moment who we went through this discussion. She said, I don't care, Belinda, I want one. We did one, very tiny thing in her liver, didn't look like breast cancer, actually looked like nothing, but wasn't on her scan when she was first diagnosed. So I then put her through an ultrasound. So she's had 2 scans now. She's taken 2 days off work. She's got young kids. Ultrasound says I can't see it. Radiologist says do an MRI. MRI is not funded. She's got to pay for that. She's got to have dye. She's got to take another day off work. And she says, stop. I don't want any more scans, right? So now I haven't ruled out that that's a met. I don't think it is. But when we do scans, we don't always stop if we find something, even if it's not breast cancer. So we often put people through a whole lot of stress related to something that ends up being something completely benign. So scans are not always the answer to everything. And this is where the liquid biopsy comes in. Because there are trials being done right now on women diagnosed with breast cancer, finish their acute treatment in that first year, and we monitor their blood every 3 months. And what we're really looking for is to see whether we can find evidence of the cancer coming back in the blood. So not on a scan, but in the blood. And I truly believe that this, when I'm giving this talk I've said 5 years, but honestly, sadly, I think it'll be 10 years, I truly believe that this will be the way we monitor breast cancer to follow up. It is not going to come tomorrow because it's expensive. We've got to make a little special genomic Mrs. Smith panel from her tumour and look for that in the blood and follow it, right? And then cause anxiety when everyone has to come and have their bloods every 3 months. And then I say yes, no. So this is going to be a long way off, but my hunch is that this will soon be available. Soon, it's not soon, but this will be available in the future, and I really genuinely hope it makes a difference to patients diagnosed with early breast cancer. I think I'm done. You were very, very polite in sitting there.
So we're going to open up for questions. So you come up to the mics if you've got questions, and I know everyone's always shy, and if nothing else, use it for a moment to be able to move. So I'll start. And because you are a med-onc, so much about all the treatment and the importance of treatment. How do we make sure that people are really talking to their medical oncologists and their other support teams about the side effects? Because we hear so often that they don't want to be a burden. I should just be lucky that I'm alive. How do we really encourage people to talk about the side effects, which clearly are impacting their quality of life?
Yeah, absolutely. So I guess the first thing to say, and I said this morning, and I think it's true, I don't think I need a mic, is that we often downplay the side effects. We do. We absolutely do. There's very good data to say your medical oncologist, because especially when they first meet you, their aim is to try and get you through that whopping conversation. So the first thing I would say is that we should be explaining them. We probably need to make sure that you get printed information, which hopefully is in language that makes sense. But even those information leaflets are not perfect, okay? And then I think you need the opportunity to be able to ask those questions again before you start the treatment. Now, that may not be coming back to your medical oncologist. You may not be able to do that. That may be your breast care nurse. That may be your surgeon, who will have had a lot of experience as well. That may be using BCNA, so there's lots of ways. I think once you start treatment, though, it's actually quite different reading it on a sheet of paper and then actually getting the side effects yourself and going, oh, is this what she was talking about? So that's when, especially if it's related to, I don't think I can do this drug anymore. I mean, you've got to be serious. I can't exercise, I can't function at work, I'm hot as hell, I can't sleep. That's a time when you should be going back to see your team. Now, does it always mean you have to come and see me? I would argue most of the time it does. And particularly when you're starting treatment, the first few months when we talk about hormone treatments is often when those things come to light. Occasionally they can rear their head down the track as well. Or something else happens in your life where suddenly, for example, cholesterol's an issue, and could be that due to Belinda's drug. Well, it could be. So I think, having the information is one thing, understanding is another, and then having your own personal experience is when you have to certainly go back, and I would use the whole team actually. I wouldn't just use one person. And it sounds a bit airy-fairy, how easy is it to get an appointment? I mean, you ring up our hospital at the moment, you wait online for an hour just for someone to talk to you. I mean, it's a disaster, right? So, we certainly need to, work on better ways to be able to get you back in if we need it. But that's actually where telehealth can be incredibly, valuable. There's a lot of downsides to telehealth. You can't examine someone on telehealth, you can't look at, but you can speak to them. And speaking to someone is really important, even if that's just the first port of call. So, yeah, I don't know whether I've really answered that, but yeah.
Well, I think just the allowing people to know that they should be asking questions on side effects, because what became so evident to us, I mean, we've known for a long time, but that webcast just brought it home on Tuesday night, the questions that were coming through, which clearly people are not feeling empowered to ask or having the space to ask because they're, feeling rushed or whatever.
Or, you don't want to admit me that this is bad, right? Classic one I get is, so how are they going? And the patient says, it's fine. And I go, fine. And then I say, so what's it like to get out of bed in the morning? They go, oh my God, it takes me like 5 minutes just to get on the edge of the bed. That's me. That's my drug. And you probably know it, but maybe you didn't want to tell me, Or I go and I say, well, you clearly need another script. And they go, oh, no, I'm fine. And you go, did your GP? You go, no, I'm fine. And then it's like, well, obviously you're not taking the medication. And it's okay. Remember, I'm on vitamin D and I don't take it, right? So we don't take medication that we hate. But it's important that, and if you don't want to be honest with your medical oncologist, the reason is you want to be honest with yourself, because there may be another medication that is better for you. The most important thing is to be on the thing that you can tolerate. There might be a smidgen % benefit from something that's a bit stronger, which if you can tolerate, fantastic. But if you can't, you won't know that there are other options unless you talk about it.
It's time for a stretch, but before we do that, a massive thank you, Belinda. It's incredible to have your knowledge and experience in the room, and I know how busy you are, and to have taken time out and to be a true volunteer to BCNA. Thank you so much. Please thank Dr. Belinda Yeo.